Hello, our dear students. We continue our cycle of lectures in discipline of Propaedeutics of Internal Medicine. As usual, I am your lecturer. My name is Maria Prince, a head of Department of Propaedeutics of Internal Medicine and Physical Rehabilitation. Today we start in a new submodule where we will learn approach to the patient and diagnostics of main gastrointestinal disorders. And first topic and our today's topic, it is the syndromes of motor function disturbances of esophagus, stomach, small and large intestine. Let's discuss plan of our today's lecture. We will discuss esophagus disorders, stomach disorders, intestine disorders, where we will include small and large intestine. And on picture you see a reminder about anatomy of gastrointestinal system. Yes, it includes a main part that we're going to discuss today, the motility of main parts we will discuss today. It is esophagus, it is stomach, it is small and large intestine, and another organs that we will discuss on next lectures. And let's start from the upper part. It is esophagus motility disorders. Let's give definition. What is that? An esophageal motility disorders are any medical disorders causing difficulty in swallowing, regurgitation of food, and spasm-type pain, which can be brought by an allergic reaction to certain foods. The most prominent one is dyspepsia. It may be a part of CREST syndrome, refers to 5 main features that include calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. And like an example, you see a first picture. It is X-ray with typical pictures of achalasia. Yes, you remember from part of physiology, it is narrowing of some organ, and here it is narrowing of esophagus. Here you see a knot of bird break appearance of the lower esophageal sphincter with dilated barium-filled esophagus proximal to it. Types of esophageal motility disorders. Here, dysphagia could be for solid only and for solid and liquid food. Yes, according to the type of motility disorder. Solid dysphagia is due to obstruction such as esophageal cancer, webs, or stricture. Solid plus liquid dysphagia is due to esophageal motility disorder or dysmotility, either upper esophagus. Myasthenia due to myasthenia gravis, stroke, or dermatomyositis. Lower esophagus, more commonly affected by systemic sclerosis, CREST syndrome, that include one more time calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. All lower esophagus can be affected by achalasia. And one more picture. It is the same patients with previous X-ray, but here you see X-ray after amyl nitrate test. It is response to the amyl nitrate. It is smooth muscle relaxant with partial relaxation of the lower esophageal sphincter. Allows some barium to pass through it into the stomach. If you see in previous picture that it was very severe narrowing, yes, it is nearly complete blockage. Here it is a partial relaxation. Causes of esophageal motility disorders. Primary causes, it is achalasia, diffuse esophageal spasm, or eosinophilic esophagitis. By systemic disorders, it is systemic sclerosis, Chagas disease, etc. Here you see one more picture, very interesting. Yes, please pay attention to right part of this picture. It is esophagram of a 65-year-old man with rapid onset dysphagia over 1 year, although esophagram shows the typical picture of achalasia. This patient had adenocarcinoma of a gastroesophageal junction. This is an example of pseudoachalasia which reinforces the absolute need for esophagogastroduodenoscopy in patients with radiologic diagnosis of achalasia. Symptoms of esophageal motility disorders. Most common of them, it is difficulty swallowing liquids or solids that we name usually dysphagia, regurgitation, heartburn, chest pain, atypical chest discomfort, vomiting, a sensation of something getting stuck, and weight loss. Please be attentive with heartburn. You always should do a differential diagnosis between cardiac pain or chest pain or cardiac angina and heartburn, for example, due to esophagus motility disorders or other gastrointestinal disorders with burning. Yes, and you see on the picture a very common symptom that you usually feel this patient. It is feeling like something in your throat. And one more X-ray with barium. Here the esophagram demonstrating a crock through esophagus picture observed in patient with manometry confirmed findings to diffuse esophageal spasm. Here you see narrowing, it not such a severe narrowing like in previous picture, but it significantly narrowed, and this place of this narrowing is prolonged through the esophagus. Diagnosis of esophageal motility disorders can be put on next main things. In patients with primary motility disorder, results of a physical examination often unrelieving. Clinical settings of scleroderma in the proper clinical settings must be noted, especially skin changes. A bedside swallowing challenge may be performed with a glass of water. Yes, very simple and very important test for such patients. Check general nutrition and hydration. Yes, it gives you a lot of diagnostical information too. If it is significant, dysphagia is reported. Sometimes patient can have nutrition problems and it can be even cachexia. Here another picture of esophagus motility disorders. On this X-ray, on this esophagram, you see a response to amyl nitrate. You remember that it is a smooth muscle relaxant with disappearance of spasm of esophagus. If caused in spasm, usually amyl nitrate can reverse it completely, and you see it on this picture that it is all okay. From previous picture, this narrowing removed completely. What diagnostic test we can use for esophagus motility disorders? One of the most specific of them, it is esophageal manometry testing, or otherwise known as motility testing, is used to evaluate the neuromuscular functions of esophagus. Yes, you see it promoted by catheter that placed in the esophagus of the patient and check pressure and motility in different levels. In level of pharynx, it is upper picture. Next, it is upper esophageal sphincter, junction of smooth and striated muscle, esophageal body, and lower esophageal sphincter. And you see, according to the pressure, according to the movements, is the motility and tonus of esophagus normal or not normal. Next disorders, it is stomach motility disorders. Yes, it is next organ that goes after the esophagus. What's the definition? Gastric motility disorders are any alterations in the transit of foods and secretions into the digestive tract. You know it. Type of stomach motility disorders. It is delayed gastric emptying or gastroparesis. It is rapid gastric emptying or dumping syndrome. It is functional dyspepsia, idiopathic vomiting, or cyclic vomiting syndrome. More causes to stomach motility disorders can result diabetes, infections, and other endocrine disorders, most often of them hypothyroidism, but can be other endocrine disorders. It is connective tissue disorders like scleroderma, autoimmune conditions, neuromuscular diseases. It can be idiopathic, and in a lot of cases when it is idiopathic, when we can't find any significant cause, but it presents stomach motility disorder. It can be psychological condition, and very often psychiatric patients suffer from stomach motility disorders. It is eating disorders, certain cancers, radiation treatment applied over the chest or abdomen, some chemotherapy agents, surgery of the upper intestinal tract. Okay, let's discuss main cases of stomach motility disorders. First of them, a very often situation, it is delayed gastric emptying or gastroparesis. Yes, it is very often, as I said, disorders. We can see it in clinic more often in aged patients, in patients with a lot of another comorbidities, and it's really big problem because it leads additionally to other problems in aged people, digestion problem and nutrition problem that worsening and in a high degree a general condition of patient. Okay, gastroparesis. It is poor emptying of the stomach that can occur for several reasons. First, it is outlet of the stomach. The pylorus and duodenum may be obstructed by an ulcer or tumor, or by something large and indigestible that was swallowed. The pyloric sphincter at the exit of the stomach may not open enough or at the right times to allow food to pass through. The normally rhythmic 3 per minute contractions of the lower part of the stomach can become disorganized so that the contents of stomach are not pushed towards the pyloric sphincter. Yes, you see these two cases. First case when it is obstructed by something, it is tumor, it is ulcer, it is some connective tissue overgrowth, or it is some foreign body. Yes, it is something large that was swallowed and blocked outcome from the stomach. And another, it is problem with sphincter. It is high tonus of sphincter or low motility of stomach that not allow normally emptying it. The diagnostic of delayed gastric emptying or gastroparesis. You see here the different diagnosis and even treatment of gastroparesis. First, it is radiologic X-ray picture. It is radiologic and endoscopic finding of delayed gastric emptying. First picture, simple abdomen X-ray shows dilated stomach food material. Yes, stomach will be enlarged here and contains a lot of liquid, a lot of something. On picture B, it is middle picture. It is severe stenosis of anastomosis site after bilirubin 1 gastroduodenostomy. Yes, it is a result of surgical operation that I told you. It is connective tissue overgrowth with stricture and with narrowing of outcome from the stomach. Opening is seen at inferior direction of anastomosis site. opening was too small for endoscopic to pass through. Ulcer lesion is seen below anastomotic site. And picture C. It is endoscopic view of gastroduodenostomy stenosis undergoing balloon dilation. Yes, it is treatment of the situation on picture B. It is luminal narrowing is seen due to anastomotic stenosis. Balloon dilated by from 20 to 25 to 30 psi was done for 2 minutes. The year develops no complications such as bleeding due to procedure. Widening of stenosis site can be seen. Yes, with balloon, the surgeons open a little bit this stenotic site. Next problem with stomach motility disorders, it is rapid gastric emptying or dumping syndrome. Rapid gastric emptying or dumping syndrome happens when the upper end of the small intestine that we name jejunum fills too quickly with undigested food from the stomach. It can be early and late dumping syndrome. Early dumping begins during or right after meal, and late dumping happens 1 to 3 hours after eating. Many people have mixed type or both type, as early as late. Okay, it is a scheme of gastroparesis. One more time. Yes, it is a fixed. It is a stopped contents of stomach that can't go to the duodenum and increase pressure and increase volume of stomach. Next disorder, it is functional dyspepsia. Many patients has pain or discomfort, fullness, early satiety, feeling full soon after starting to eat, bloating, nausea. That is felt in the center of the abdomen above the belly button. Yes, it is a very, very often disorder, true, but if we said about gastroparesis, for example, that it is more often for aged patients, functional dyspepsia, it is mostly a disorder of more young patients and not aged adults or even teenagers. Yes, there is no single motility disorder that explains all these symptoms, but about a third of patients of these symptoms have delayed gastric emptying, usually not so severe that it causes frequent vomiting, and about a third show a failure of the relaxation of the upper stomach following a swallow or abnormal gastric accommodation reflex. About half of the patients with these symptoms also have sensitive or irritable stomach, which causes sensations of discomfort when the stomach is filled with even small volumes. Here you see a scheme of pathophysiology from escape of functional dyspepsia. Yes, it is consists pathophysiologically from several syndrome, from several processes. Yes, it is visceral hypersensitivity of visceral receptors. It is disrupted gut immune interactions. It is abnormal upper GI motor reflex functions. It is psychosocial factors, it is genetic factors, but it is discussion about genetic factors and genetic predisposition to functional dyspepsia. And but like version, it is okay. And it is altered brain-gut interactions. All these factors together, or some of these factors together, can give such process of functional dyspepsia. Why it is functional? Why we name it like this? Yes, in general, when we name disease functional, we means that problem just with function. Organically, morphologically, it's all okay. And during all our investigation of tissue, of organs, of structures, it will be all okay. We will not find anything in the biochemical or CBC We can't find anything on endoscopy, on X-ray, but patient have symptoms. Yes, it is a problem, of course it is a problem, but we name it functional problem because we can't find anything with organical or morphological structure. And in case of stomach, we name it functional dyspepsia. Next syndrome, it is cyclic vomiting syndrome. Cyclic vomiting syndrome is a disorder with recurrent episodes of severe nausea and vomiting interspersed with symptom-free periods. Cyclic vomiting syndrome occurs in all ages. Patients may struggle for many years before a correct diagnosis is made. Symptoms, it is nausea and vomiting. It is retching or dry heaviness. It is bloating. It is upper abdominal pain, stomach fullness after the normal sized meal, early fullness satiety with inability to finish meal. It is weight loss due to a decreased appetite. To diagnose in general stomach motility disorders, what diagnostic tests we can use? Yes, we name it gastric motility procedures. The most modern and one of the most informative and less invisible, less hard for the patient, it is Smart Pill Wireless Motility Capsule. What is that? Smart Pill Wireless Motility Capsule, it is a pill-sized sensor that is swallowed and measures temperature, pH, pressure, how quickly the stomach empties, how quickly the small intestine and colon empty. Next test, it is test for Helicobacter pylori or H. pylori testing can be done with a blood antibody test. It can be done more simply with a breath test, stool antigen test or stomach biopsy. Breath testing can be helped to detect a food intolerance, bacterial overgrowth, irritable bowel syndrome, fructose intolerance, lactose intolerance, or constipation. And here you see devices for Smart Pill Wireless Motility Capsule. You see the size of capsule. It is quite small. It is looks like a big drug capsule. It consists of two parts. First part, it is external part of it. It is individual for each patient, of course, and internal part with the sensors, with the camera. It is not individual, it is changed in another external capsule and it can be used for another patients. Yes, and it can be analyzed with such specific analyzer that you can see in first picture in the left side of the picture, and on computer we got a lot of diagnostic information from these diagnostic devices. Yes, we discuss it is pH, it is motility of stomach, motility of intestine, and other parameters. H. pylori testing, yes, the most simple for screening for H. pylori. It can be pylori strip. Yes, it is dilution or extraction of buffer. Yes, that we use. Move there the strip for 10 minutes, and like for pregnancy, yes, for with two lines it is positive, with one line it is negative for H. pylori. Helicobacter pylori breath testing, yes, it is the most simple, it is not invasive, not difficult for patient at all. In expiration ear, we can detect urea in the ear, or urea breath test. and according to level of this C. urea, we can suspect is it present or absent H. pylori in this patient. And let's start discussion of intestine motility disorders. Let's give a definition to all of them. Firstly, the phrase intestinal motility disorders applies to abnormal intestinal constructions such as spasm and intestinal paralysis. This phrase is used to describe a variety of disorders in which the gut has lost its ability to coordinate muscular activity because of endogenous or exogenous causes. And here you see one more time, I remind you innervation of gastrointestinal tract. How it looks like, that it's spinal nerves, splenic nerves, celiac ganglions, sympathetic chain, spinal root, dorsal root, and from thoracic spinal cord it goes this innervation. And problems in all these links in all these places can lead to abnormal motility, abnormal movements of intestine. One more time, mechanisms. Yes, first of all, it connects to innervation of gastrointestinal tract and innervation of intestine. Here one more time you see scheme of control of gut motility. It is interaction between extrinsic neural pathways and intrinsic nervous system. Causes of motility disorders. Yes, we told that most of them connected to the innervation, but not all. In most cases, causes seem to be multifactorial, and only few have been detected. First, it is degeneration disorders cause pseudo-obstruction along with other problems. It can be using of some drugs. Commonly used drugs, it is tricyclic antidepressants, diuretics, laxatives, or have specific indications like lithium salts, vinyl alkaloids, and other chemotherapy agents. They may interfere with intestinal motility. Sometimes endocrine disorders, yes, it is most of all a severe stage of hypothyroidism or myxedema, we name it, can also lead to pseudo-obstruction. Moreover, some role plays genetic factors. Manifestation of intestine motility disorders. The most often it is abdominal distension, recurrent obstruction, severe abdominal colicky pain, severe constipation, GI reflux disease, intractable recurrent vomiting. Yes, and if we talk about constipations, here you see scheme with 15 the most often causes of constipation. It is, you know that it is very often problem, that's why causes of them are very important to learn. It is poor diet, it is lack of exercise, medications, underactive thyroid, IBS, perianal pain, neurological conditions, pregnancy, traveling, potty training, bowel cancer, laxative abuse, stress, poor toilet habits, not enough water. Clinical forms of intestine motility disorders. First form, it is intestinal pseudo-obstruction or Ogilvy syndrome. It is irritable bowel syndrome, the most often form. Moreover, it can be fecal incontinence and constipations. Diagnostic test for intestine motility disorder. First of them, endoscopic ultrasound. a very interesting test that can show us a lot of useful information. And here on this picture from endoscopic ultrasound, you see the anterior defect in external and external anal sphincter that can lead to constipations and abnormal motility of intestine. We have a specific classification of intestine motility disorder that names the Knowles-Martin classification. According to it, the delayed colonic transit, slow transit constipation, including enteric neuropathy, enteric myopathy, Parkinson disease, endocrine disorders, and spinal injury. Next type, it is dilated colon, diffuse or segmental. It is Ogilvy syndrome and megacolon, and absent recto-anal inhibitory reflex or Hirschsprung disease. Another test for diagnosis of intestine motility disorders, it is GI scintigraphy. It looks like this. It can be used much more rare because it is a quite difficult and expensive test. But in this case, it was very informative. Here in these 2-hour images, note the normal emptying, 31% empty. Normal range for 2 hours, it is from 31 to 67%. In the left image, with significantly more tracer shown in the small intestine than in the right image, which shows dilated emptying, 26% emptying, and much less tracer in the intestine. Symptoms of intestine motility disorders. It can be pain, it can be bloating, it can be disturbed bowel motion, it can be feeling full after having eaten only a small amount, nausea, vomiting, severe constipation. And here you see a very interesting picture. Why I include here? Because it is one of the most effective ways for treatment of this problem. The treatment of motility disorders of intestine and motility disorders of GI in general, it is good and regular physical activity. And here the most effective, it is cardio activity. And here you see a woman that ran during 30 minutes 3 times a week. It is not too much, it is not too long time, but it usually enough for normal habits and normal motility of the intestine of each person. And even for patient with some problems, it usually effective for normal movements and normal stool. And just only patient with very severe organical problem or neurological problem can have problems even after physical activity. And more than 90% of all cases of constipations, of other motility disorders, of irritable bowel syndrome can be resolved by regular cardiac or other physical activity. Let's continue diagnostic. Diagnostic motility testing can be provided by endoscopy and X-ray endoscopy. And you see these pictures here. First picture, it is the placement of guide wire for motility catheter. Yes, it is catheter that check pressure like I showed you in esophagus. It can be placed the same catheter in the intestine to check motility, to check pressure in different parts of it. And second picture, it is X-ray picture of placements of colonic motility catheter. Physical examination of patients with intestine motility disorders. The clinical picture of patients with intestinal motility disorders is per 10 and may vary greatly depending on the specific condition present. Always perform a digital rectal examination in any patient with an intestinal motility disorder to detect the presence of a mass, including feces, tumor, or foreign body, or blood in the rectum. One more additional instrumental test, it is defecography. It looks like on the picture. On first picture you see the anterior rectus cella, and on next picture, second picture, it is anterior rectus cella that does not empty completely. Syndrome of maldigestion and malabsorption. Let's give definition to it. It is another big problem with our intestine. It can be, it must be a lot of time for discussion of this topic, and it is big topic in gastroenterology that you will have on fourth course, and it is a big part of different GI books, but today very shortly about these syndromes. We don't have enough time, but please read more at home. At the lecture I can give you just the main things. What is maldigestion? First of all, let's give definition, and please learn for yourself this definition. Maldigestion describes the inability of an individual to digest food in the gut. And malabsorption, it is inability to absorb nutrients that have been digested from food through the gut. Maldigestion, it is inability to digest. Malabsorption, it is inability to absorb digested food. What organs damage can lead to maldigestion and malabsorption? First of all, I can tell that it's not just GI system, a multifactorial, multi-organ problem from all systems and all organs can lead to maldigestion and malabsorption, including the problems with liver, problems with bone, with lung, brain, blood, heart, muscle, pancreas, egg, sperm, and other system and organ. All our body can be affected by abnormal nutrition due to maldigestion and malabsorption. Causes of these syndromes. It can be congenital heart disease, it can be cystic fibrosis, it can be gastroenteritis or chronic inflammation of intestine. It can be HIV infection, liver disease, short bowel syndrome, toddler's diarrhea, etc. Symptoms of maldigestion and malabsorption. GI manifestation. It is as diarrhea, steatorrhea or fat in the stool. It is weight loss. It is flatulence, it is pain, it can be abdominal bloating, abdominal cramps, abdominal discomfort, swelling or edema, and muscle cramps. Histological examination. Usually the final diagnosis we can put just after histological examination of the intestine and confirmation why food can't be digested or can't be absorbed, what exact cause of this problem. Extraintestinal manifestation. I told you that it is a multi-organic problem, and it includes such symptoms. Patients with celiac disease present with anemia and osteopenia in the absence of classic gastrointestinal symptoms. It is microcystic and macrocytic or dimorphic anemia may reflect impaired iron, folate, or vitamin B12 absorption. Purpura subconjunctival hemorrhage may reflect hypoprothrombinemia secondary to vitamin K malabsorption. Osteopenia is common, especially in presence of steatorrhea. Impaired calcium and vitamin D absorption and chelation of calcium by unabsorbed fatty acids resulting in fecal loss of calcium may all contribute. Dermatitis and peripheral neuropathy may be caused by malabsorption of specific vitamins and micronutrients and essential fatty acids. Moreover, it can be other non-GI symptoms and very huge range of these syndromes and symptoms that can be caused by maldigestion and malabsorption, and each of them connected with deficiency of some nutrients, of microelements, of vitamins, of proteins, and other. Let's stop on main of them. One of the most dangerous, most often it is vitamin B12 deficiency. You discussed all this process, all this pathophysiology in pathophysiological classes. One more time for remind you scheme of this the deficiency of B12 lead to pernicious or microcytic anemia. Both maldigestion and malabsorption can lead to deficiency, for example, in vitamins and minerals as well as protein and energy. Yes, we discuss all of them. And these processes can lead to a big range of different complications. The complications that can develop depend upon which nutrients are affected. For example, a calcium and vitamin D deficit can lead to rickets and osteopenia. Iron deficiency is associated with anemia. Zinc deficiency has been linked to poor growth. Problems with absorbing protein, fats, and carbohydrates can culminate in weight loss and undernutrition with wasting and, in severe cases, stunting. Here you see problems with vitamin D. Yes, you know that it leads to different neurological problems, growth problems, and vitamin D deficiency in children can lead to severe deformations of bones. Diagnosis of maldigestion and malabsorption syndrome. There is no single specific test. A range of different conditions can produce maldigestion, malabsorption, and it is necessary, of course, to look for each of these specifically. Many tests have been advocated, and some, such as tests as pancreatic function, are complex, vary between centers, and have not been widely adopted. Tests are also needed to detect the systemic effects of deficiency of the malabsorbed nutrients, such as anemia with vitamin B12 malabsorption. Here you see one more time pathophysiological scheme of malabsorption. Yes, it is a problem with mucus in intestine. Yes, through the receptors, through the lumen, it is normal absorption of nutrients to the capillaries. What blood test scheme of blood tests that we usually prescribe patient with maldigestion or malabsorption? It is routine blood tests may reveal anemia, high C-reactive protein, or low albumin. For microcytic anemia is usually implies iron deficiency, and macrocytosis can be caused by impaired folic acid or B12 absorption or both. You know it. A low cholesterol or triglyceride may give a clue towards fat malabsorption. Low calcium and phosphate may give a clue toward osteomalacia from low vitamin D. Specific vitamins like vitamin D or micronutrient like zinc levels can be checked. Fat-soluble vitamins are affected in fat malabsorption. Prolonged proton beam time can be caused by vitamin K deficiency. Immunoglobulin A antitransglutaminase antibodies or IgA anti-endomysial antibodies for celiac disease, or another name of this disease, gluten-sensitive enteropathy. It is congenital disorder that often can be seen in children. Here is a scheme of fat malabsorption. One more time, you see main causes of malabsorption. It is lymphatic obstruction, it is reduced small intestinal surface, it can be iatrogenic due to some medical or surgical manipulations. And you see schematically pathophysiology of fat malabsorption. Stool studies for maldigestion and malabsorption. Microscopy is particularly useful in diarrhea, may show protozoa like Giardia, ova, cyst, and other infective agents. Fecal fat study is diagnosed. Diarrhea is rarely performed nowadays. Low fecal pancreatic elastase is indicative for pancreatic insufficiency. Chymotrypsin and pancreatolauryl tests can be assessed as well. One more time, it is connection of diarrhea due to different causes and malabsorption. Here on the scheme you can see how it looks like. And in the end of our today's lecture, I want to give you for your individual work for your interest one USMLE test. A 22-year-old female presents to your office with gas, abdominal distension, and explosive diarrhea. She normally enjoys eating cheese, but has been experiencing these symptoms after eating it for the past few months. She has otherwise been entirely well, except for a few days of nausea, diarrhea, and vomiting earlier in the year, from which she recovered without treatment. Which of the following laboratory findings would you expect to find during workup of this patient? And options. First, it is decreased stool osmolar gap. Second, decreased stool pH. Third, positive fecal smeller for leukocytes. Fourth, positive stool culture for rotavirus. And fifth, positive stool culture for Tropherema viplae. Okay, it is test for you. That's all for today. If it is interesting for you, in the comments or in our Facebook page, you can write your options. And as usual, if you have comments, if you have questions, or you want to write us something, you can write it in our closed Facebook group under the link to this lecture. For today, that's all. See you next lecture, when we will continue discuss of problems and diagnostic of these problems of GI system. And for today, that's all. Goodbye.